Okay, right. So the today's class, the next 1 hour, 1.5 hours, right? Uh, I just want to discuss some basics of cardiology, right? Actually, I'm doing this as a pre-class before I start the cardiology proper, right? Cardiology proper on coming Tuesday, right? So we'll just talk some basic aspects of cardiology before moving on to the right cardiology proper, where we are going to discuss the full-blown medicine of cardiology. Right? Can you hear me? Right, okay. So coming to the basics of cardiology, guys, right? I start from one of the, that one of the basic things we have to understand is we all study this anatomy, physiology, blah, 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 right? So you study 100% of your anatomy, physiology, but you have to know only the 5%, right? So only the 5% you are supposed to remember, but that 5% you are supposed to remember forever, right? So that you are not supposed to forget, right? You will just keep the videos on, guys. That's easy, right? Otherwise, it's a bit irritating to teach. That's the reason, right? So I'll just show you the way to approach, right? How to approach, right? Even the small juniors may be there, right? You will also get an idea how it's going to be, right? Okay. So coming to the basics of cardiology, you are aware about the normal structure of the heart, where we are having 4 chambers, 2 atrium, that is your right atrium and the left atrium, and you have the right ventricle and the left ventricle, right? And we all know the right atrium has 2 main openings where it gets the venous return from the superior vena cava, right, which carries the blood from the upper part of the right body. And the next venous return is coming from the inferior vena cava. This superior vena cava and inferior vena cava both open into the right atrium. I just want to emphasize one point here. You may remember, if you remember your anatomy, if you look at the opening of the superior vena cava and inferior vena cava, there is no valve here. That's the important point here. The opening of this vena cava into the atrium, so these openings, they do not have a valve. They do not have a valve, because this point is important, guys, because tomorrow, when we are studying about the jugular venous pressure, JVP, right, JVP, so there are some changes occurs just because of that. There are some waveforms which occurs in the JVP because of this. That's why this anatomy is important. So now whatever the blood coming to the superior vena cava and inferior vena cava to the right atrium, it is coming to the right ventricle, and there is a valve that is a tricuspid valve, right? And from the right ventricle, the blood is pumped into the pulmonary artery. You may remember the circulation here. Right, from the right ventricle, the blood is pumped into the pulmonary artery. So it is going to the lung, where the blood is oxygenated in the lungs, and then the blood is returning from the lungs, right? The blood is returning from the lungs, where the 4 pulmonary veins, So if you look at these 4 pulmonary veins, right, they are opening into the left atrium. Opening into the left atrium. Just mute your video audios, right? Opening into the left atrium. From the left atrium, the blood is coming to the left ventricle, and from the left ventricle, the blood is pumped to all over the body except the lungs, right? Even the lungs, there is some supply, but the main thing is, right, lung circulation is from the pulmonary artery, which is coming from the right ventricle. So this is how the normal blood pumping is taking place. So between the left atrium and left ventricle, we are having another valve. That's your mitral valve, right? Mitral valve. So this is the same thing I have told you, right? The blood is pumped from the right side to the lung, and it is coming to the left side, the oxygenated blood, which is oxygenated in the lung, and that is pumped to all over the places, right? So why this is important is, guys, right? There are a few things to understand, right? So if you look at this structure carefully, right? So this right side is pumping blood only to the pulmonary artery. At the same time, the left side is pumping blood into the aorta, or all over the body. So because of that, compared to the right side, the left ventricle, the wall thickness is very much high. Wall thickness is very much high. Since the wall thickness is very much high in the left ventricle, so when the left ventricle is contracting, there the oxygen demand is high, right? There the oxygen demand is high. Clear, guys? So because of that, whenever there is a decrease in the blood supply, right? Whenever there is a decrease in the blood supply, right? So the left ventricle is the one which is commonly undergoing the infarction, right? Infarction. Now, if you look at this valve, guys, I just want to say the next point here. This is your tricuspid valve. This tricuspid valve is connected to a structure here called chorda tendineae, right? Sorry, papillary muscles, by these fibers. These fibers are called chorda tendineae, right? So your tricuspid valve is connected to the papillary muscles by the chorda tendineae. Similarly, if you look at the left side, right, left side, this mitral valve, right, the mitral valve is connected to the, right, the mitral valve is connected to, again, to the papillary muscles by chorda tendineae. But you can't see that here, right? What is this valve? Pulmonary valve. And you can't see that in the aortic valve here, right? So in other words, this structure, this chorda tendineae, papillary muscles, right? This chorda tendineae, papillary muscle structure is not seen when it comes to the, what you say, your aortic valve or pulmonary valve. Again, this anatomical point is important because tomorrow we are going to study in cardiology. When there is a heart attack, so in the medical term, we call this as myocardial infarction, right? Myocardial infarction. So what will happen is, guys, these papillary muscles can rupture, right? These papillary muscles can rupture. So this valve structure, the integrity of the mitral valve, right? This integrity of the mitral valve, it depends on this chorda tendineae and the papillary muscle structure, right? The problem is tomorrow when there is a problem with the myocardial infarction, right? Myocardial infarction, right? There is no YouTube, you just join it now, right? Okay, here, this is not a film, no, right? So when there is a myocardial infarction, right? So because of this rupture, it can affect the mitral valve. It can affect the mitral valve. So there's a topic called valvular heart disease where we are going to discuss. This is something called mitral regurgitation. Mitral regurgitation. Clear? So that's a basic anatomy to start off with. The four chambers, the valves of your heart, right? Valves of your heart and the ventricular thickness, right? Now, I just want to say a few points here, guys. Look at these, few points here, right? So don't think anymore heart is like this, right? Heart is no more like this. Clear? So this is how your heart rests in your body, right? This is how your heart rests in your body. So why this is important? The heart is resting like this, right? Is, now look here. If you look at this inferior surface, right? So this is the inferior surface of the heart, right? Inferior surface of the heart. So if you look at this inferior surface, so you can see that is, what is the structure? Diaphragm, right? Yes, diaphragm. The inferior surface is sitting on top of the diaphragm, right? Sitting on top of the diaphragm. Clear? So since the inferior surface is sitting on top of the diaphragm, right? So sometimes a problem will come, right? Look at this, guys. When you have a heart attack, or in the medical term, it's a myocardial infarction, which is affecting the inferior surface, like the bottom of the heart, like the lower surface, instead of a chest pain, they can come with a pain here in the abdomen. That's your epigastrium. Clear? Right? So sometimes, right? So the patient might come with a pain here. It's still a heart attack, even though the pain is not in the chest, but in the epigastrium of your abdomen. Understood? Right? So that's how the inferior myocardial infarctions will come. So that's why in surgery, like, so if you remember your surgery, the epigastric pain is one of the hot topics in surgery, yes or no? Right? So there, other than the surgical causes, where you can have epigastric pain, we have a few medical causes which can present with a epigastric pain. One is this, inferior myocardial infarction, right? Okay. Then later you will study in endocrinology, or you studied already in endocrinology, right? Endocrinology. So the other place, right? Other where you can have a epigastric pain due to a medical reason is in the diabetes. You have remembered there's something called diabetic ketoacidosis. Yes or no? Right? They can also come with an abdominal pain. Clear, guys? So just because the patient is there in the surgical ward, that does not mean the patient is having a surgical problem. You have to know there are some rare medical causes which can come with an abdominal pain. One is this, the reason is this. Understood, guys? Yes or no? Right? Tell some surgical causes, by the way, which can present with epigastric pain. Peptic ulcer disease, chronic or acute pancreatitis. Yes or no? Peptic ulcer disease, chronic or acute pancreatitis. Right? Chronic or acute pancreatitis. Perforation of the peptic ulcer. Right, perforation of the peptic ulcer. Right? So those are the main causes. Right? So the left surface, guys, look at this. It is mainly from the left ventricle. Right? And the upper end, there is something called left auricle. Right? So if you look at the borders of the, I tell you why this is important. Right? People, that again, you have to know only the very basics which is required clinically. No point in studying anatomy or physiology or pathology. It's completely useless, wastage of time. That's what we have done in the university now. We can't do the same mistake again. So if you look at this, right? So I want you to know, if you look at this right board, right? If you look at this right board, this is formed by the right atrium, okay? If you look at this inferior border, the lower part of the heart, this inferior border is formed by the right ventricle. This inferior border is formed by the right ventricle, right? So if you look at this left border, it is formed by the left ventricle, right? Left ventricle. Why this is important, guys? Right? Look at this, guys. This is what you are going to get tomorrow, right? Once you start practicing, right? So you'll just get a chest X-ray like this, right? So when you get a chest X-ray like this, you should be aware this is the right atrium. What you see here, this right border is the right atrium. Right border is the right atrium. So what you see here is the left border is the left ventricle. So this inferior border is the right ventricle. And here we have the aortic arch, this arch of aorta, aortic arch. We have the aortic arch. And here we have the superior vena cava, right? The opening of the superior vena cava. Right? X-ray is not going to be named, no? Right? X-ray is not going to be named. But when you see an X-ray like this, for example, if this is, somewhere, look here, if this is dilated, right? You have to know, okay, this is the left ventricle is dilated, right? There is an enlargement of the left ventricle, right? There is an enlargement of the left ventricle, right? There is an enlargement of the left ventricle, right? Understood? Right? So you have to know where is the problem when you see an X-ray like this. In other words, what I'm trying to see is, when you get an X-ray like this, it is not named. This is named, no. What you have to see is, your brain should think like this, right? Your brain should think like this. This is the way to approach the X-ray, right? So if there is something abnormal here, okay, this is something going on with the right atrium. If there is something abnormal here, there is something going on with the left atrium. Sometimes this will be enlarged, guys. We study a condition called mitral stenosis. Yeah, this will be enlarged. So there's something to go with the left atrial appendage. Right? Okay. So in other words, what I'm trying is, so just get this type of mentality now onwards. Right? Okay. So I just want to say about a few words about the layers of the heart. Layers of the heart. So you know the layers of the heart, there are three things. Right? Three things. There is a epicardium outside, or the pericardium. The pericardium outside, which has two things actually. If you look at the pericardium outside, there are two pericardiums. You may remember, one is called parietal pericardium, P-A-R-I-E-T-A. Other one is visceral pericardium. Right? Parietal pericardium and visceral pericardium. So this visceral pericardium is the one which you are calling as the epicardium. Epicardium. Then next to that, right, next to that, we are having the myocardium, which is your muscle, right? This is the one, don't write on the screen, guys. This is the one which is, what you say, forming the bulk of the muscle. Then inside, right, inside, you are having a endocardium, right, that is underlining the ventricular surface, right? So we have two pericardiums, you know, parietal pericardium outside and then the visceral pericardium. So between the two layers of your pericardium, there is a potential space, right? There is a potential space, right? So this is what we are going to talk tomorrow, right? When there is a problem there can be a pericardial effusion. When there is a fluid there, it's called pericardial effusion. People, just keep the cameras on, please. Yeah. Make sure you keep the cameras on. Okay, right. Fine. Look at this. This is a must. This is something you have to know forever. Right? The blood supply of the heart. Blood supply of the heart. So you may remember the heart, the blood supply comes from two main things. No? There are two coronary arteries. Left coronary artery and what do you say, right coronary artery. So if you look at the left coronary artery, when I look here, right, left coronary artery, right, okay, this is how it starts, guys. This is how it starts, right? So it starts from there, like there's something called, what do you say, aortic sinus. It starts from the aorta, from the left posterior aortic sinus, right? It starts from the aorta, from the left posterior aortic sinus. Left posterior aortic sinus, right? So once it has started, the initial part, let me look here. The initial part of this artery is called left main coronary artery. The initial part of this artery is called, right, this part, right? So this part is called left main coronary artery, right? Left main coronary artery, right? Left main coronary artery. So this is called LMCA, left main coronary artery, LMCA, right? So now this left main coronary artery is dividing into two. One is coming here, guys, between the two ventricles. So the anatomical name for that is anterior interventricular artery, right? Anterior interventricular artery. Don't do this stupid works, eh? We also know this. Like if you know at your age this much, how much we know at this age, right? Right? I was ask you to look at by your screen itself. Right? Okay. So this is called left anterior interventricular artery. Left anterior interventricular artery. So even though it is called anterior interventricular artery, right, anatomically, the medical term what you are using in the angiogram, etc., what you used to call it as LAD. What is LAD? Right? This is how you use it in medical terms. Even though the anatomical term is left anterior interventricular. Left anterior descending artery, right? Left anterior descending artery. So it comes and supplies the, right? It comes and supplies the, right, anterior surface of the ventricles, right? Both the left and the right, right? And here, once it is given, there is another branch given called left circumflex artery, which is going round like this. So why this is important? This is supplying the lateral side of the heart, right? Lateral side of the heart. Okay. Then you have the right coronary, right coronary. So which is starting from here, from the anterior aortic sinus, right coronary. So this right coronary comes and curves behind like this, right? And right coronary is the one which is mainly giving a part to the inferior surface of the heart via these posterior interventricular artery, right? Posterior interventricular artery. So at this point, right, it gives another branch here which is called marginal artery, right? You have to have some idea about these guys forever. This is something you can't forget what you say at any point in your life, right? Okay, right. So in about 90% of the people, the posterior interventricular artery is given by the right coronary artery. That's why we are saying they are right dominant, right? The same thing what I said, right? So these are the areas supplied by each artery, right? So left anterior descending is supplying, look at this, right? Left anterior descending is supplying some part of the right ventricle. It supplies the left ventricle as well as the septum, right? As well as the septum. So circumflex artery, again, you can see circumflex artery, right? It supplies the left ventricle as well as the left atrium, right? Left atrium, right? So the right coronary artery, right atrium, right? And remember these 2 points. So there is something called conduction system of the heart, right? So this right coronary artery is the one which is supplying the SA node as well as the AV node, right? Because we study tomorrow, right? When it comes to the right heart blocks, right? There will study the problem is with this artery. Whenever there is a block in the right coronary artery, they can develop heart blocks, right? This posterior interventricular artery is giving the posterior surface. There is a right ventricle, left ventricle, and the interventricular septum, right? Okay. So basically, guys, one of the important point is, like, these arteries are there, right? These arteries are there. So it looks like there are small anastomosis here, right? Small anastomosis here. Like if you look at the picture. But the clinical point is these anastomosis are useless. Right? These anastomosis are useless. What do you mean by the word these anastomosis are useless is if you have a block in one artery, right? Say somewhere a block here, a block here, a block here. So the area supplied by that artery, right? Area supplied by that artery will undergo infarction. Is going to die. Right? Whatever the blood coming from the other arteries are not clinically adequate to prevent the infarction. Infarction means death. Prevent the infarction of death. Right? So the anastomosis, right, are usually not enough to prevent the infarction when there is when there is a obstruction of an artery, right? So the next point, guys, I'm just telling the very important clinical points only. Yeah. So this is not to teach what is anatomy or physiology. The next point is what I want you to understand is the blood in the heart is coming from outside to inside. Like blood coming from heart is coming from outside to inside. In other words, let me look here, from the epicardium to endocardium. The most outer surface is epicardium, no? The blood is flowing from most outside part, epicardium to endocardium. Right? So here you have the myocardium, yeah? Right, here you have the myocardium. This is a myocardium. And the out part is epicardium. The inside part is what? So out part is epicardium, inside part is endocardium. So why this is important is, guys, right? So later we'll study in cardiology, right? There's something called cardiac cycle, right? So there's something called systole. There's something called diastole. What is happening in the systole is your ventricle contracts. Your ventricle contracts. So what is happening in the systole is your ventricle contracts. So when the ventricle, this is a myocardium, right? Myocardium. So when the ventricle contracts, that will compress these vessels, right? When the ventricle contracts, that will compress these vessels, right? So why this is important is, right? Why this is important is, so in systole, since these vessels are constricted, right? Since these vessels are blocked, right? It's just like this, no? Contract and compress like this. So this part, guys, just below the endocardium, these are called subendocardium. This part is not going to get the blood, right? This part is not going to get the blood, right? So in other words, what I'm telling is, this part is going to get the blood only in diastole, right? This part is like going to get the blood only in where? Diastole. So why this is important? Right? When the diastole is short, right? Diastole is the time where your heart relax, right? Heart relaxes in diastole. So when the diastole is short, so this part just below the, just below the endocardium, this part, right? This part, there is a decreased blood supply, right? That's a basic anatomy, physiology, pathology, etc. Right? Okay. Is it okay, guys? Shall we move on to the next one? Ischemic heart disease introduction. Yeah. Okay. One more thing. The students, the cardio sessions will start on coming Tuesday, right? So those who want to register before the Monday 4 o'clock. Don't wait for the last moment, guys. A headache, right? And this KDU, professorial, and I know some universities are starting on September 1st, right? Like in the Russia, etc. So there will be restreaming for the session 3 and the section-wise papers. Because the section-wise model papers, we are going to do 4, right? That is in the morning time, no, Wednesday morning. So the people from KDU and the other local other foreign universities, some of you may not be able to join on that time. So just because of that reason, I arranged this, restreaming for that, right? So if you miss a class, you can contact and watch. It's not a big issue, right? Clear, guys? And once this is over, everything will be over, right? For those who have started even the Corona, for those who missed that, we'll again restream those things, right? And the third year, fourth year, second year, whoever who are here, I think now it's you're about to finish the syllabus, no? Right? So you sit in a proper way, right? Don't just have an aim of passing with a 45. Don't come here if you want to pass with 45. Just go somewhere else. I'm not bothered, right? So just try to score as much as possible, right? Say maybe your target may be 65. So your target may be 75. Another one might be 85, right? So to the maximum of your ability, that matters, that matters, right? So it will come throughout your life. Even if you become a consultant, your rank matters, right? Because everybody will become a consultant, it's not an issue, right? So, but your rank matters, right? Even to get a quarters, the rank matters. So even if you look at the last time, right? Out of the first 15, only one or fifth or somewhere, only one student was not there in the class. All the others were there in the same order in the first 4. First, second, third, fourth, like that, right? You all know this is going to be the order. Again, those who topped were lucky last time, right? They were able to get the medicine surgery, right? The people who topped the rank last time were lucky because that was a small local intake, right? A lot of ERPM students, so they were able to get it. But that is not going to be the case in the future. So sometimes you may be going to the internship with 1,000 local graduates, right? So you will be 1,001, right? Right, okay. So in that case, the rank matters. Otherwise, you may have to do the, pediatrics and genomes for your internship, like completely useless, right? So the MBBS, no, right? Bachelor of Medicine, Bachelor of Surgery, right? So that, right? I mean, it's okay, right? But like better to do at least those who want to do, at least those who want to do. So try to score as much as possible, right? As much as possible, right? But do some work, as I always say, do some work. And the section-wise papers, when the theory is over, there are section-wise papers, right? And there are final papers, that's the thing, right? 25 theory classes and 4 section-wise papers, and then the final papers, depending on the numbers, 15 or whatever it is, we'll do, right? The numbers won't change. Numbers won't change, and what do you say? There won't be any crash course, this course, that course here. There's only one course, this is the course, right? So you have to follow that and do it, right? There's no point in putting several classes under several names again. I hope you can also understand, right? Clear? So just make the maximum and do the questions. Do the questions. And those who are starting their section-wise papers on, Wednesday, I will give the paper on Monday. Just do. Like marks is 15, doesn't matter. So I got only 15, it doesn't matter, right? So if you have 15, I know how to make it 50 next time. But if you are somebody who have not attended the paper, you also have no clue where you stand. I also have no clue where you stand, right? So 5 marks is okay, provided you do and come, right? So that's where the thinking is coming, guys, from your part, right? Okay, right, okay. There's a few things for that, right? Okay, fine, look here. And whatever things you are missing, the notices and those things, either join the ERPM Medicine Forum Facebook page as well as a Telegram group, right? Now the ischemic heart disease. The hottest topic in medicine, or the very basic core of medicine. Everywhere, the ischemia means there is a decrease in the blood supply to the heart, right? Decrease in the blood supply to the heart. How can you have a decrease in the blood supply to the heart? Let me look here, right? Most of the time, guys, right? Most of the time, or 90% or even more. So this is the vessel. There is a blockage in the vessel, right? There is a cholesterol plaque in the vessel, right? There is a blockage in the vessel, or there is a cholesterol plaque in the vessel, right? Cholesterol plaque in the vessel, right? So when there is a blockage or cholesterol plaque in the vessel, so the amount of blood going distal to that is going to be reduced, right? It's going to be reduced, right? So the distal part, like what is after this plaque, is going to get low blood. So that's what you call as ischemia, reduced blood supply. But I just want to say one point, guys. I just want to say one point here. Even though this is the common way, right? Right, okay. Don't think this is the only way. Right? Don't think this is the only way. Right? How can you have a decreased blood supply to the heart? The common thing is the cholesterol plaque or atherosclerotic plaque. But this is not the only way. Sometimes, just know it. Sometimes your vessels are normal, guys. Like sometimes your vessels are normal, completely normal. Even if you do an angiogram also normal. What patient is having chest pain? Right? Patient is having chest pain. How is he having? Various possibilities. Sometimes these vessels undergo spasm, contraction. Right? For some reason or the other, they are contracting. They undergo spasms, contraction. Right? That is one reason. Right? You can have a pain. Sometimes nothing is okay, nothing abnormal. Like say you have a severe anemia. You have severe anemia. What is anemia? Right? There's a reduction in your hemoglobin. So because of that, even though the blood is going, it is not carrying adequate amount of oxygen. Right? it is not carrying adequate amount of oxygen. Again, you can have a chest pain. Again, you can have a chest pain. Right? Sometimes everything is normal. Like no anemia, no spasm, no plaque, everything is normal. But still there is a chest pain. Right? Okay. Because sometimes, what is happening is, the demand is high. Your heart is working more. Since the heart is working more, you have a very high demand. You have a very high demand, right? So the demand is high. So because of the high demand, right? Because of the high demand, right? So there is a inadequacy compared to the supply, right? Compared to the supply, right? So I just want to say one thing here. The cholesterol plaque, right, or the block is a common reason, but just remember that is not the only reason, right? That is not the only reason. There are things out there in that test, right? Okay. So if you look at the ischemic heart disease, okay, if you look at the ischemic heart disease, we are dividing that into two. One is called stable angina. Stable angina. What is this stable angina is, right? So these people, their blood supply is adequate to meet the demands of the heart at rest, right? So they are stable at rest. They are stable at rest, right? But the problem is when they are on exertion, for example, when they walk, when they run, when they do a heavy work, so that time their blood supply is not adequate, right? That time their blood supply is not adequate, right? Okay, so that is the time they develop the chest pain. Otherwise, when they are at rest, they are okay. They are okay, right? So that's what it's called, stable angina, right? That's right, right? It's called what? Stable angina. Clear? So they are, as the name says, they are stable at rest. Stable at rest. Right? Okay? Stable at rest. So why this is happening like this? Right? Why this is happening like this? So if you see why this is happening like this, the reason is, so there is a block. This is a blood, like this is a blood supply, like this is a vessel. They have a block. They have a block here, right? But what will they have is, right? If you look at this block, I draw a cross section like this. If you look at this block is there for a long time, long standing block, right? So if I do a cross section, this is your cholesterol plaque, right? Atherosclerosis plaque. This is your cholesterol plaque, right? Atherosclerosis plaque. If you look at this plaque, right? If you look at this plaque is a long-standing plaque. It is there for a long time. This is there for a long time, right? And this is nicely covered, guys. This is nicely covered. This is nicely covered, right? So there is a nice fibrous capsule, right? It's covered by a nice capsule, fibrous capsule, right? Fibrous capsule. So if the plaque is there for a long time, the distal to that area, there is decreased blood, right? Distal to that area, there is a decreased blood. But this problem is there for a long time, right? This problem is there for a long time. So since this problem is there for a long time, right? Since this problem is there for a long time, right? Okay, this problem is there for a long time. What they will develop is, they develop new blood vessels like this, right? To bypass that, they develop new blood vessels. It's called collaterals, right? It's called collaterals, right? It's called collaterals. Right? These new blood vessels, collaterals, they give some supply, right? They give some blood supply. So whatever the blood supply given by these collaterals are adequate to meet the demands when they are at rest. When they are at rest, whatever the blood you get by these collaterals are enough, right? The problem is, right? The problem is, if they are on exertion, right? If they are on exertion, what do you mean by that? If they are on exertion, when they walk, when they run, your demands of the heart will increase, because why the demands increase? The heart rate increase, right? The heart rate increases. Second, the contractility of the heart increases. The contractility of the heart increases. Right? Contractility of the heart increases. So when the demand increases, whatever the blood you get from the collaterals are not adequate now. Right? They are adequate to meet the low demand at rest, but they are not adequate to meet the high demands when they are on exertion. Right? They are not adequate to meet the high demands when they are on exertion. Clear? So if you ask this patient, they will say, doctor, I am okay at rest. I don't have a chest pain at rest. When I walk, I have a chest pain. When I stop, the chest pain stops. They are stable at rest. You call it as stable angina. Clear? You call this what? Stable angina. Right. So the next one. If you look at this next one, the next presentation here, how an ischemic heart disease can come to you, is by something called acute coronary syndrome. What is acute coronary syndrome is, these are the people who come with a acute chest pain, sudden chest pain, right? Sudden chest pain, right? These are the things which you call in layman terms, right? These are things which you call in layman terms heart attack, right? What a layman mean by the word heart attack is this, acute coronary syndrome, right? So later, guys, we study in the right, what do you say? We study in the cardiology. We are dividing this into various types, this acute coronary syndrome, depending on the ECG. And there is something called cardiac biomarkers. I'll come back to that point again, right? So this acute coronary syndrome, people look here. These are the people come with a sudden onset pain, sudden onset chest pain, right? Sudden onset chest pain. So why these people come with a sudden onset chest pain, right? Why these people come with a sudden onset chest pain? Because the problem is, guys, right? What makes the difference here? What makes the difference here is, this is like this, just an idea. I'll teach you in the first class also. Here also there is a cholesterol plaque. This is a vessel, this is a cholesterol plaque. So if I draw it and cut it, look here, look here. If I cut it and if I draw it here, this is the cholesterol plaque. This is the atherosclerosis plaque. This is the atherosclerosis plaque. So if you look at the stable angina, I told you this plaque is there for a long time now. Like stable angina, I told you there's a long time plaque. Yes or no? Huh? Long time plaque. But if you look at this plaque, this is a young plaque. This is there only for a short time. This is there only for a short time. Plus, at these borders, right, at these edges, you call these borders as shoulders of the plaque, right? There is something called inflammation. Inflammation. So what will happen is, because of this, now look here. What about the stable angina? What about the plaque in the stable angina? It's a long-standing plaque. It's there for a long time. Yes or no? Right? The initial one, stable angina, the cholesterol plaque or the plaque is there for a long time. But it's a short time. Stable angina, there is a nice capsule. Yes, nice capsule. But it does not. There is no well-formed capsule. It does not have a nice capsule. There is no well-formed capsule. It does not have a nice capsule. There is no well-formed 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 capsule no well-formed capsule. Clear? What will happen is, guys, this will rupture, guys. This capsule will rupture. No, this is not well-formed, right? This is not well-formed. So this is going to rupture. When this rupture, this is blood. This is blood. This is cholesterol. Right? This is cholesterol. This is cholesterol. So when this ruptures, right, this is the capsule, no? This is the blood. This is the cholesterol. When this ruptures, blood and cholesterol will come into touch. Right? Blood and cholesterol will come into touch. Right? So there will be a big thrombus formation. There will be what? Thrombus formation. There will be a thrombus, thrombus formation. There will be a thrombus formation. Right? So suddenly the whole vessel will be clogged. Whole vessel is blocked. See? Right? It was like, look here. It was like this half clot. Now this ruptured. So there's a clot formation. Everything is clogged. Everything is clogged. The vessel is blocked. Vessel is blocked. Vessel is blocked. Right? So this is only there for a short time now. This was only there for a short time. Since this was only there for a short time, you don't have collaterals. You don't have collaterals. No blood supply. No blood supply at all. So they will come with a chest pain. Right? Understood? Yeah? How many classes you had today? Huh? Too much. Right? Right. Okay. Right. Look at this. So, people, this is what I told you. Okay. This is what I told you guys. The same thing what is there. Right? Same thing that is there. What I discussed now. Right? The block, etc. Right? So, this is the same thing I told you. When this ruptures, right, this is a cholesterol plaque. So this is the blood. These come into touch, and there is a thrombus. There is a thrombus. When there is 100% block, 100% block. So what you develop is called, when there's 100% block, what I'm going to develop is called ST elevation. I'll come back to that point. ST elevation. When this is not 100% block. Look at this, guys. Right? So if it's 100% block, you are going to develop this one, third one, something called ST elevation. When this is not 100% block, not 100% block, what I'm going to develop is called unstable angina, or there is something called non-ST elevation. Non-ST elevation. Right? I'll come back to this point again. So acute coronary syndrome, there are 4 things, guys, under that. How to divide into these 4 depending on the ECG, and there is something called cardiac markers. Cardiac markers. One is unstable angina, other one is non-ST elevation myocardial infarction, other one is ST elevation myocardial infarction, other one is new onset left bundle branch block. New onset left bundle branch block. Right? New onset left bundle branch block. Right? Fine. Now look here. Right? Okay. What is this? ST elevation MI. What is this? Non-ST elevation MI. What is this? What is meant by this? Right? What are these things? So these are the things when what we are right, what are we talking or what are we dividing by looking at the ECG. By looking at the ECG. By looking at the ECG. Right? By looking at the ECG. Normally, guys, right? Okay, normally, if you look at the normal ECG, what is ECG? Right? What is ECG? Right? What is ECG? Right? Listen here. What is ECG is you are trying to detect the electrical activity of the heart. You are trying to detect the electrical activity of the heart by looking from outside. Right? You may remember if you look at the electrical activity of the heart, there is something called SA node. SA node. Yes or no? This SA node is called, I will talk in the cardiology, don't worry, yeah, pacemaker of the heart. This is called the pacemaker of the heart. Right? This is called the pacemaker of the heart. So what will happen if you look at the electrical activity? The current will come from the SA node to, there's something called AV node. AV node, AV node, AV node. Right? From the AV node, right, it will come via something called His bundle, and there is something called Purkinje fibers. Purkinje fibers. Right? This is how the electrical activity, the current is going in the heart. So what you do in the ECG, you are trying to detect this by putting some leads outside your body, right? By putting some leads outside the body to diagnose this electrical activity, right? To diagnose this electrical activity. Okay. So if you look at a normal ECG pattern, guys, right? Right, look at this. This is how a normal ECG pattern looks like, right? So initially you have a wave here, right? This is called P wave, right? I'll do a separate class on ECG, don't worry, right? This is a P wave, P wave. Then we have a wave here, which is called QRS. Then we have something called the T wave, T wave. Then we have something called this here as U wave. Rarely you will see this, right? So if you look at the P wave, what is this P wave shows? This is the depolarization of the atria. So I told you, right? I told you here that, okay, look at this once again. Right? I told you, if you look at the current is going from the SA node to AV node, right? SA node to AV node. Then from the AV node, right? So in other words, when the current is going from the SA node to AV node, what is happening here is, right? That's what you call as the depolarization. Depolarization of the atria. Then the current will go from the atria to the ventricle. While the AV node, the current will go from the atria to the ventricle. So then what is going to happen there? That is the depolarization of the ventricle. Right? Depolarization of the ventricle. Right? Depolarization of the ventricle. Right? Then your heart is, this is D, yeah? Then the heart will repolarization, will come back to the normal state. So if you do an ECG, so what you see here is, you see something called a P wave. What this P wave say, this is the depolarization of the atria. Then you have your QRS, right? Usually there is no Q wave, there is R and S. Right? Usually there is no Q wave. We study in cardiology when there is a Q wave. So what this shows is, this is depolarization of the ventricle. Depolarization of the ventricle. Right? Then your heart is coming back to normal. This is called repolarization, right? This is your PQRS, this is your T wave. This is called repolarization of the ventricle. That's what meant by the, meant by the T wave. Clear? Now what I want to tell is, remember guys, these three are same line. It's in the same line. These three are in the same line. You call this as isoelectric, 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 right? Isoelectric. So this is the part, let me look here, look here, look here. This is the part you are going to call that as ST segment, ST segment, ST segment, right? ST segment. So what will happen is, right, when there is a 100% blockage, complete blockage, we are going to develop a heart attack called ST elevation myocardial infarction. ST elevation myocardial infarction. Myocardial infarction. Okay. What is happening there? Let me look here. Look here. This is how now, no. This is how the normal ECG is there. Yes? Yes or no? Right? This is the R, this is the S, this is the T. So what will happen in the ST elevation myocardial infarction is, right, this ST segment will go up like this. This ST segment will go up like this. This ST segment will go up like this. Clear? Okay, guys. Right? Now, the other two, when the block is not 100%, right, say about 70%, 80%, like that. When the block is not 100%, what are they going to develop is called non-ST elevation myocardial infarction, right? Or sometimes this term is not that much used now, unstable angina, unstable angina, right? Unstable angina. Okay. So what these people don't know, it's just an introduction. I will study there in the class, right? This is the P wave, right? This is your R wave, S wave. This is a T wave now. This is a normal ECG. So what will happen in these people is ST elevation myocardial infarction. There was a ST elevation now. So in these two conditions, what they can have is they can have something called ST depression. What is ST depression? Right? If you look here, right? Your ST segment will go down like this. ST segment will go down like this. ST depression. The other thing they can have is they can also have T inversion. They can also have what? T inversion. Right? So normally T is like this, no? Upwards, upwards. So here what will happen is, right? Normal T is like this, upwards. Here what will happen is your T wave will come like this. I'll do a separate ECG class, I don't know yet. Like I'm just telling some very basic points now. Like T wave will come like this. And by the way, guys, I hope all of you are having this stet, etc. Yes or no? Like stet, etc. I promise at the start, I will do some practical sessions, right, for the students who are attending my theory sessions, right? And okay, hopefully maybe not the next week, the other week, I will have these practical sessions, right, at Sigma, right? Practical sessions at Sigma, right? I actually discussed with Dr. Barnacle today, right? We are thinking about a date because both of us might be doing on the same time, right? On the same time, it's easy for us. So you can also, it's easy for you also, come to both practicals on the same time, right? And possibly I will take by years, right? Second year, third year as one batch, or the first year, second year as one batch, something like that, right? We'll once we finalize the time and the slots, right? We'll let you know. You can finish both and go, right? So probably not the next week, the other week we'll do. I'll also talk to the patients also. It's like this, guys. The plan will be like this, eh? Somehow you find a state, otherwise it's difficult, right? Okay. It's useful for everybody, right? Say roughly say there are 10 patients, right? 10 patients roughly, right? 10 patients, for example. So you have to come at your allocated time. At every patient, there will be somebody to teach you, right? So how to hold the skate, how to auscultate, how to check the pulse, like that, right? How to look at the lungs, right? How to check the reflexes, like that. So once you finish off one station, you have to move to the next station, right? Like that, you have to, like, it's like a carousel, you have to go through the whole circle, right? So that's the thing. Once we have finalized everything, I'll let you know the time and those things. Yeah, it's better if you have your own equipment. Anyway, it's needed no one day, right? Even if you have 3D or whatever it is, one day is needed, right? Right. Always better to practice from your own one rather than the others. Right. Okay. So this is the thing. The next thing, guys. Look at this now. The next point. Now, these are ECG changes now. These are the ECG changes now. Can you please include the exam batch too? Yeah, yeah. Without you, right? You are always included. Don't worry. Right? ECG changes. Look at this. Now I look here. It's like this, no? This is supplying this area. This vessel is supplying this area. Yes or no? So if there is a block here, this area will undergo what? Infarction. Infarction is called cell death. Say this blood vessel is supplying what? This area and the inferior surface. So if there is a blockage here, right? If there is a blockage here, this part will undergo infarction. Yes or no? Come on, guys. Yes or no? Right. This is okay, no? In that case. So there is, we saw there is a, sorry, this one right corner here. Right, this is the right corner. Okay. Right, this is the left corner. We said there is something like this, no? The left corner is dividing into this is the left main coronary artery. This is the left anterior descending artery. This is the left what? Circumflex artery. So if there is a block here, what will undergo infarction? This area will undergo infarction. Yes or no? Huh? So what are you doing is to undergo which part is undergoing infarction, you are looking at the heart from various angles. Right? What your ECG does is, right? The ECG is looking at your, say, some are looking like this, some are looking like this, some are looking at the heart like this, some are looking at the heart from the bottom. Your ECG is looking at the heart from various angles. By looking at the heart from various angles, right? So ECG is able to point out where is the problem, right? Right? So I'll come back to this one, guys. This is what I told you guys, right? Right? Okay. So this is what you see in a ST elevation MI. Your ST segment is elevated. Can you see that? Yes or no? Huh? Elevated. So if you look at the non-ST elevation MI, ST segment is what? Depressed. And they can also have T inverse. So those are which is a non-ST elevation MI. I'll come back to this. Right? Okay. Right, look at this, guys. Right. Fine. Now, have you seen an ECG? Yes or no? Huh? So what you do in the ECG is, how many leads are there in the ECG? How many leads are there in the ECG? Come on, guys, tell somebody, tell. Unmute and say.
12.
6.
There are 12 leads. What are the 12 leads? We are having something called chest leads, guys. Chest leads. Look at this, I'll tell you. These are the V1 to V6. V1 to V6. There are something called AVR, AVL, AVF. These are limb leads. AVR, AVL, and AVF. And there are some summation leads, lead 1, lead 2, lead 3. So altogether 12 leads are there. Right? Okay. Right. Now, okay. Come on, look here. This is how a normal ECG looks like. Don't worry about the lateral inferior. Just look at this. This is how a normal ECG looks like. Right? Say, you can see now this is V1, V2, V3, right? V1, V2, V3, V4, V5, V6. Right? So you can see here, this is a lead 1, 2, 3, lead 1, 2, 3. These are the AVR, AVL, AVA. Right? Right? Okay. Just go to this photo. Lead 1, lead 2, lead 3. Right? AVR, AVL, AVA. Right? Right? Okay. This is a V1 to V6. Right? Is it okay? Right now, look at this. The normal ECG look like. Now, what are we doing is, guys, as I said, we are putting various leads, right? We are putting various leads to look at the heart from different angles. So I told you there is a V1 to V6, V1 to V6. So you put leads like this guy. Say you put the V1 here in the fourth intercostal space in the right side. So this is looking at the heart from this way, right? You put the V2 here. This is looking at the heart from this way, this way, this way. You put the V3 here. This is looking from this way. V4 here, this way. V5 here, this way. V6 here, this way. So you are looking at the heart from different angles, right? Different angles to find where is the problem. Where is the problem? Clear? Okay. So our V1 is looking in this way. V2 is looking in this way. V3 is looking in this way. V4 is looking in this way. V5 is this way. V6 is this way. Is that okay? Right? Yes or no? Huh? Come on, guys. Somebody unmute and tell.
Yes, sir.
Yes.
Yeah? Okay. Now, this lead 2, lead 2, lead 3, lead 3 is a nice photo. This lead 2, lead 3, AVF, AVF. These three are looking at the heart from the what side? Inferior side. Yes or no? Inferior side. From the bottom. So if you look at the photo, you understand, right? Lead 2, lead 3, AVF is looking at the heart from what side? Inferior side. Inferior side. Right? Okay, guys. Right? So if there is a problem in the inferior side of the heart, if there is a problem in the inferior side of the heart, so if there is a problem in the inferior side, in other words, what is that? Inferior myocardial infarction, heart attack. Right? Okay. If there is a problem in the inferior side, so if there is an inferior myocardial infarction, heart attack, right? Inferior myocardial infarction. What are the leads you expect the changes to be? Tell guys, please. Huh?
3 AVF.
Lead 2, 3 AVF. Why those are three things which look at the bottom? Yes or no? Which look at the bottom? Come on, guys. Are you okay? Right? Say, we don't have anything to look at the posterior side now. Right? We don't have anything to look at the posterior side. Yes or no? But there is a posterior side of the heart now. Yes or no? So when you think there is something going in the posterior side, right? When you think there is something going in the posterior side, you put some new leads, guys, which you don't do in a normal ECG. Right? Right? You ask the ECG technician to put some leads. Look at this, V7. Normally it is not there in the normal ECG. V8, V9. You ask the technician to put some new leads at the back, to look at the posterior side. Right, okay? Clear? Similarly, look here. What is this side of the heart? What is this side of the heart? Tell. Huh? Right ventricle. You can put some leads on this side of the right side. V3R, V4R, V5R. You can put some leads on this side, right? Put some leads on this side, right? To look at the right ventricle. Clear? Just have some idea. I will discuss in the ECG class. Just have some idea. Understood? Right? Okay. Now, right. So this is, look at these guys. Right? Okay. The same thing I told you. The V1 and V2 is looking at the septum of the heart. V3 and V4 is looking at the anterior surface of the heart. Right? V5 and V6 is looking at the lateral surface of the heart. Right? Lead 2, 3 AVF is looking at the inferior surface of the heart. Right? Inferior surface of the heart. Nice to see some names here in the list. Good. Right? Inferior surface of the heart. Right? Lead 1 and AVL is looking at the lateral surface of the heart. Just tell one more time. What are the leads which are looking at the inferior surface of the heart? Just tell, then you remember. Huh? Tell. Lead?
AVF.
Lead 2, 3 AVS. Good. What is looking at the lateral surface of the heart? Look at this and tell. Huh?
An AVL. One AVL.
Lead 1 AVL and sometimes V5, V6. V1 to V4 basically looking at the anterior surface of the heart. Clear? Now, just for the sake of interest, I mean, you are very small. I don't want you to. Do you see any abnormality in this ECG? Huh? Do you see any abnormality?
Elevation.
Huh?
ST elevation.
ST elevation, excellent. Have you all found this ST elevation, guys? Yes or no? Huh? Have you found this ST elevation? Here. Can you see? Tell guys, yes or no? Huh? Yes.
Yes.
What are the leads you see ST elevation main? Tell me the main leads. What are the leads you see the ST elevation?
V1, V2, V3.
V1, V2, V3, V4. Yes or no?
V4.
V1, V2, V3, V4. So this is what MI? Tell the first one. It's a ST elevation. Come on, guys, tell. ST elevation, MI. Yes or no? ST elevation, MI. Do you understand that? Yes or no, guys? Yeah? What side of the heart is affected? If the ST elevation is the V1 to V4, what side? Yes?
Anterior.
Anterior ST elevation, MI. You all got it? Yes or no? Right, is that? Don't worry, there's a separate ECG class. Right? Fine. That we'll discuss. But just know the basics. If you know the basics, the life is easy. Right? You don't have to go and memorize. The same way we do the neurology, as simple as that. I don't think anybody will come and tell now the neurology is difficult. Okay, now look.
මට අහන්න PowerPoint එක share කරන්නද කියලා කවුද?
Yes, could you please mute your mics? Okay, that's enough. Yeah. Now this I'll keep it later. Left bundle branch block, how to diagnose in the ECG, I will tell you later in the class. Don't worry now at the moment. Right. Now, this acute coronary syndrome, right? Acute coronary syndrome. How are you going to diagnose this acute coronary syndrome? Right? I'll come back to this point later. Don't worry yet. Don't worry too much. There are three things to diagnose this acute coronary syndrome. There are three things. The one thing is the one I told you now, this ECG. But the very first thing is the pain. Right? The very first thing is the pain. Right? So the third thing is there is something called cardiac biomarkers. I'll come back to that word again. Cardiac biomarkers. So coming to this pain, look here, coming to this pain. Now, one of the very basic teaching in medicine is, right, basic in medicine is acute chest pain. What is acute? Right? It starts like this. It starts like this. The myocardial infarction or MI or whatever it is, heart attack in general terms, is a vascular event. Like what we study in our stroke. Right? Like what we study in our stroke is a vascular event. Always remember the whole mark of a vascular event is, right, sudden onset. Right? Sudden onset. Clear? So one of the basic teaching is, guys, look here. Right? One of the basic teaching is, right? Basic teaching is, whenever there is a clinical thing with the acute onset, right, the vascular event should come first. So here, we all know this comes with a chest pain. This MI myocardial infarction will come with a chest pain. Clear? So if you look at this acute coronary syndrome, we don't write that. Just I'll teach you in cardiology. Don't worry. Just don't worry about writing now. One of the very basic teaching is acute coronary syndrome, right? Acute chest pain is acute coronary syndrome until proven otherwise. Right? Acute chest pain is acute coronary syndrome until proven otherwise. That is one of the very basic teachings in medicine. Right? What do you mean by that? Now, you are having a chest pain today. Right now, you are after the class, you are sending a message, says chest pain. What's the diagnosis? Huh? 4 classes per day. Right? You were there in the chair for 14 hours or more than that, and you're having a pain because it's a mechanical pain. But how else you can have a chest pain? Tell me something. How else you can have a chest pain? It can be a problem on the skin. Don't write. We study separately. It can be a problem in the skin. It can be a problem in the muscle. It can be a problem in the bone. It can be a problem in the pericardium. It can be a problem in the lungs. It can be a problem in the pleura. Understood? But the teaching is acute chest pain is acute coronary syndrome until proven otherwise. So there are 100 causes of acute chest pain, but the acute chest pain is acute coronary syndrome until proven otherwise. You can miss 99 causes, it's okay. You can't miss an acute coronary syndrome. Understood? You can't miss a heart attack, right? So unless you exclude that, right? Unless you exclude that, when somebody comes and tell you, doctor, chest pain, that is an acute coronary syndrome, heart attack, until proven otherwise. Got it? Right? There can be 100 causes, but 99 you miss. No issue. This you can't miss. So the message is tomorrow, whenever there is a doubt, at least you have to do the ECG. Clear? There are few features, guys, right, which will tell you this pain is more in favor of your acute coronary syndrome. If you look at the character, it's a tightening pain. Dr. Tadakanage, Vikramai, it's a tightening pain. Right, if you look at the location, remember, it's behind the sternum, retrosternal, behind the sternum, retrosternal. Clear, guys? Thing is, the clinicals or art, like clinicals or art, is something you have to develop by yourself, right? You have to develop by yourself. Nobody else, what do you say? We can teach, but like you have to find your own way, like. So that is something it's very important, right? To develop during the medical student life, guys. It's very important, right? So when we were students, right? Now I have no more exams to be done. It's almost a consultant now. Right? If I have to do, I have to do a PhD, right? Actually, there's no need for a PhD. I will do it, but anyway, just because of the sake, there's nobody better than me in the country, right? So that's the only reason. Otherwise, it's clinically no point for me to have a PhD. Anyway, I will join the university. That also I need the PhD to get, you say, the rest of the things. This professorship and those things will come with a PhD, right? Now there's no more exams to sit anymore. MD also done. So one of the basics what we have done is we didn't study hours and hours, but we had our own way of finding, right? Even as a medical students, right? We had about 3-4 people together, right? So you don't, there's one of the mistakes the students will go is they will go and what do you say, see hundreds of patients. No point. Right? No point in seeing hundreds of patients. But even if you say 5 patients, that 5 should be properly done. Right? 5 should be properly done because this issue will come. You'll understand later once you go for the Viva. These 5 things, the problem among students and those things. Right? So we had 3 friends, right? So like we never like one behind the patient, like when at night or somewhere we'll go, right? One will do, okay, this is this, right? Other one will observe. Other one will tell, okay, no, you are going in a wrong way. This is not this. This is this, right? This is this, right? So that's that's the way to go, guys, right? And we were all rewarded because of that, right? So you can even just go and check. No, this is not a Facebook advertisement. What is it? If you look at Island Bank, I was the first, and the other one was the 4th. Other one was the 7th. All island, right? That was a final merit list, right? So this, why I'm telling this is you have to have your way. Right? Everybody can't do the same way, Now, this is withdrawal now, guys. Tomorrow in the exam, the best thing is don't ask the patient where is the pain. Okay? Don't ask the patient where is the pain. Patient will come up with 100 things. They are humans, right? And they are not educated like us. So the best thing is, look here. You ask, show me where is the pain. Understood? You point and show me where is the pain. Right? With your finger, you touch and tell. They will touch here. Understood? They will touch here. Right? The next point. These are points for life. Radiation. This pain will radiate to the jaw, shoulder tip, left arm. Right? The message for you guys. Look at this, guys. Look at this. Right? Sometimes, we come across people, even though we say this is the pain, everything is not according to the textbook, right? So the patients may not come with a classic pain, like classic pain. They will not tell the, consecutive pain or anything. But as budding doctors, my message is, if somebody tells you, doctor, the pain is going to the neck, understood? Right? Pain is going to the neck and the jaw. Never ever ignore that pain. Clear? Never ever ignore that pain. Right? Understood, guys? Yeah? Because that is always significant. Right? That can be something we are missing, right? Right? So it's like never ignore that pain at all. Right? And the left side of the forearm. The severe pain, guys, intensity wise and the duration wise, is lasts about more than 20 to 30 minutes. Right? So aggravating factors, any activity will increase. If you look at the stable angina, look here. I told you stable angina, when you walk, there is a pain. When you stop, your pain stops. But that is not the case here. Right? Here the pain will be there. Right? Pain will be there. Right? Pain will be there. So what are the other things they are having? That can be associated factors, sweating, nausea, vomiting. Not only that, they can even have diarrhea, right? They can even have diarrhea, right? Even have diarrhea. Okay, right? So that's about the pain, guys, right? I'll teach you the cardiac biomarkers later. I just want to say what is cardiac biomarkers is, right? Don't worry about it now. Cardiac biomarker is cardiac biomarkers, like cardiac biomarkers, are enzymes. They are what? Enzymes. They are enzymes. They are released to the circulation, right? When there is a damage to the cardiac muscle. When there is a damage to the cardiac muscle only, right? Normally, in a normal person, you don't find these enzymes at a significant level unless there are some, what do you say, other conditions which are elevating these enzymes. There's a third thing we are looking to diagnose there, what do you say, acute coronary syndrome. Understood? Are you there with me? Right? So shall we call it a day with that? Yes? Okay. So this is just an introduction before starting the cardiology, guys, right? Okay. Then we stop with that. Okay, fine then. Okay, good night.